Welcome to The Explainer. We're here to cut through all the noise of the wards and help you lock on to the absolute clinical signal. Look, if you've ever stood at the bedside of a crashing patient and just felt totally overwhelmed by the sheer mountain of lab data and imaging, you are exactly in the right place. Today, we're going to unpack some of the most absolutely crucial tipping points in internal medicine. We're talking about those split-second moments where physiology suddenly shifts and your management has to pivot literally instantly to save a life.
All right, here is our survival guide for navigating these high-stakes scenarios. We're going to cover the SOG gradient, differentiating cirrhosis from heart failure, the biliary pressure axis, moving from Charcot to Reynolds, and finally, the hyponatremia trap. Let's just dive right in.
Section 1. The SAG gradient, structural permeability versus hydrostatic back pressure.
So picture this. A clinical lawyer sees a patient with a superdistended abdomen, maybe some shifting dullness, and boom, they automatically order high-dose loop diuretics. But we need to act like the clinical judge here. The judge demands a hard, absolute audit before making a move. And we do this using the SAG formula, taking serum albumin and subtracting ascites albumin. You guys, this isn't just some abstract math problem. It is the ultimate diagnostic tool to figure out what is actually driving the fluid buildup in the first place.
And right here, this is the magic number, 1.1 grams per deciliter. That number is a brilliant dividing line. It's the absolute threshold where our diagnostic pathway completely forks. A result above this number sends us hurtling down one pathophysiological road, and anything below it, we're taking an entirely different route.
Okay, look at this patient. When you see classic signs like this, a really distended abdomen, maybe you notice some jaundice, spider angiomas, or muscle wasting, the SAAG value is what anchors that abstract gradient to their real physical presentation. I mean, sure, you might suspect cirrhosis just by looking at them, right? But the SAAG gives you the definitive, objective proof of what's literally happening at the microscopic sinusoidal level. So here is exactly how we interpret that dividing line. A high SAG, meaning it's 1.1 or greater, tells us your sinusoidal barriers are actually intact. But there's this immense hydrostatic back pressure, like what you see in portal hypertension, that is just driving transudative fluid out. On the flip side, a low SAG, well, that points to leaky, damaged membranes that are spilling albumin straight into the peritoneal cavity. And that is a massive red flag for a primary peritoneal pathology. Think along the lines of carcinomatosis or peritoneal tuberculosis. Moving on to Section 2, cirrhosis versus heart failure. Let's navigate the high SAG matrix.
Okay, so let's say your SAAG is high. Great, but is it a cardiac issue or a hepatic one? This is where we run a signal versus noise audit. Normally, total ascites protein is just, background noise when you're trying to calculate the primary driver. But within a high SAAG matrix, it suddenly becomes pure signal. A total protein value over 2.5 grams per deciliter tells us we have preserved sinusoids that can still produce protein, and that points straight to congestive heart failure. Conversely, if it's under 2.5, we're looking at fibrotic destroyed sinusoids, which is the absolute hallmark of cirrhosis.
Section 3, the biliary pressure axis. We're looking at the shift from simple stagnation to sepsis.
Check out this timeline. It perfectly maps out the diagnostic dividing line. We start with biliary colic, which is that transient pain lasting a few hours when a stone temporarily blocks the cystic duct. Now, if that stone gets stuck in the common bile duct, you've got choledocholithiasis. That can actually last for days, causing jaundice and pain, but usually without systemic toxicity. But here comes the tipping point. When that stagnant column of bile becomes infected, that is acute ascending cholangitis. And let me be clear, that is a massive emergent medical crisis.
Section 4, Charcot to Reynolds. Let's identify this critical tipping point.
We typically start with Charcot's triad, fever, right upper quadrant pain, and jaundice. That triad tells you there's an infection brewing. But when that mechanical biliary stagnation crosses the line, you get Reynolds pentad. By adding hypotension and altered mental status to the mix, it means the intrahepatic pressure is now so incredibly high, it's literally pushing bacterial endotoxins backward into the hepatic veins. Guys, at this point, you are looking straight at systemic endotoxemic shock.
Take a look at this matrix. If your patient is emergent, you need to jump on broad-spectrum IV antibiotics immediately, something like piperacillin tazobactam. But please, listen to me here. Do not make the fatal mistake of delaying urgent decompression just to get a secondary ultrasound when your patient is crashing in shock. Actually, scratch that. It's not just a mistake, it's a disaster. A patient with Reynolds Pentad needs an immediate ERCP or a PTC drain if ERCP isn't an option, to drain the pus and halt the shock. It's a plumbing problem, right? You have to fix the pipe.
Section 5. The hyponatremia trap. This is a massive iatrogenic pitfall you have to watch out for.
So imagine you're looking at a chart and you see a sodium level of 132. Not crazy low, right? But if you blindly restrict fluids without checking their intravascular volume first, you are walking straight into a trap. If you have a cirrhotic patient whose low sodium is actually driven by overdiuresis rather than free water retention from splanchnic vasodilation, restricting their fluids is going to tank their renal perfusion. You'll literally precipitate deadly hepatorenal syndrome.
To avoid this, you absolutely must follow this strict algorithm. First, always assess the volume status. Second, figure out the underlying cause. Are we dealing with heart failure, SIADH, or maybe GI losses? And third, you have to respect the absolute speed limit for correction. We're talking no more than 8 milliequivalents per liter over 24 hours for chronic hyponatremia. You have to go slow.
Because if you don't go slow, you risk an absolute nightmare. When you look at an MRI like this and see a zone of demyelination in the basis pontis, that is central pontine myelinolysis. Rapidly shifting the extracellular sodium exerts immense osmotic pressure. It literally pulls water straight out of the neurons in the brain, shrinking them down and completely destroying their myelin sheaths.
And the pons, right down in the brainstem, is exceptionally vulnerable to this kind of injury. Honestly, it's a profound tragedy because it is entirely preventable, yet the consequences are catastrophic. This kind of rapid overcorrection can leave a patient trapped in locked-in syndrome. That means they are totally awake and conscious, but essentially paralyzed. They can't move or communicate at all, outside of maybe just blinking their eyes.
So, as we wrap up this explainer, I want you to really think about this question. I want you to think critically about these boundaries when you're out there on the wards. Whether you're doing the math on a sag gradient, recognizing that terrifying shift from Charcot to Reynolds, or just pausing for a second before you hang that IV fluid for hyponatremia, always ask yourself, what true signal might I be missing in all this noise before I write that next order? Thanks so much for joining me today. Keep learning, keep pushing yourselves, and I will see you next time.